Let me share my screen again. Okay, Dr. Kishore.
Yes.
Yes, can you hear me?
Yes, yes.
Okay, so this is a 8-month-old girl was brought to your hospital emergency department with complaints of fast breathing. This child is referred to your hospital by a general practitioner after 3 days because the symptoms did not improve. Now the child has difficulty in breathing, cough, and expiratory wheeze. She has been receiving oral antibiotics and cough suppressants. Her elder sibling had upper respiratory tract infection 1 week back, and there are no family history of any atopic diseases. So when you went to the ER, you saw a well-developed child. There are no congenital abnormalities. Weight and length are normal for age. Temperature is 100.4 degrees Fahrenheit. Blood pressure is 90/65. Heart rate is 140. RR is respiratory rate is 65 per minute with nasal flaring and intercostal retractions. So pulse oximetry shows 94% in room air. She is alert but dyspneic, and nose contains copious clear mucus. So when you auscultate the chest, there is prolonged expiratory phase with in-expiratory wheeze. Except for that, other systemic findings are normal. So with this history, can you make a provisional diagnosis?
Yeah, in my opinion, it is bronchiolitis in respiratory distress.
Okay, so your provisional diagnosis is a bronchiolitis in respiratory distress. Any other differential diagnosis?
Other might be pneumonia or foreign body. I'd like to rule out foreign body as well.
Okay, so why do you keep a bronchiolitis number 1 and pneumonia number 2 and foreign body aspiration at number 3? How do you differentiate?
Yeah, the age of the child is 8 months, which is the common age for bronchiolitis, and there is history of contact with the elder sibling who was having upper respiratory tract infection 1 week back, and the child is tachypneic, alert, but he was dyspneic, but he's alert. And on auscultation, there is wheeze. Bilateral, there was wheeze. So my diagnosis goes in favor of bronchiolitis in respiratory distress.
So is there any importance of history of atopy in this child?
Yes, there is in the history. This is the first episode, and there is no any history of atopy. History of atopy is important here. And the child anthropometric measurement, all they are normal, so which rules out these chronic lung problems.
Okay, so bronchiolitis in respiratory distress seems to be your provisional diagnosis. So do you need any investigation to confirm your diagnosis?
Basically, the bronchiolitis is a clinical diagnosis, and we can do chest X-ray to rule out other causes like pneumonia or other foreign bodies.
So in this child, will you go for chest X-ray?
Yeah, I'll go for chest X-ray to rule out other causes.
It's 8 o'clock.
Okay, but the recent guidelines regarding bronchiolitis, what they say is if you do a chest X-ray in a bronchiolitis patient, you are more likely to have a diagnosis change into pneumonia.
So in the periphery, like we are practicing here, basically we do chest X-ray to rule out other causes.
Okay, so in periphery, what we are doing is for a bronchiolitis case, we go for chest X-ray. So are we going for a complete blood count?
Yes, we can do to rule out other causes. We can do baseline CBC and CRP, and we can also do PCR for this RSV.
Okay, so bronchiolitis is most commonly caused by respiratory syncytial virus. So if there is a facility, you can go for a PCR for RSV. You are saying that?
Exactly.
Okay, so any other investigations you would like to do?
I think this investigation is enough for this child.
Okay, so you are saying these investigations are not compulsory, but you can go for these investigations in a peripheral setup.
Yes.
Okay. So what about the treatment then? How would you proceed?
Basically, the management is conservative management. So first of all, we'll do nasal suctioning. As the child is having copious nasal secretion, then we will give antibiotic and we will maintain the hydration, and we can give humidified oxygen.
Okay. So will you go for antibiotics, whether oral or intravenous?
For bronchiolitis, there is no need of antibiotics. So I
So
won't give antibiotics to this child.
yeah, but this child is having nasal flaring. So would you like to go for steroids?
Steroids is also contraindicated in this bronchiolitis. We can give this 3% normal saline nebulization.
Okay, so you want to try with 3% normal saline.
Yeah.
Why not go for salbutamol or adrenaline?
There is no role of this adrenaline and salbutamol in bronchiolitis.
Okay, but can we try with salbutamol nebulization? Because in Nepal, what we see is most of the patients with bronchiolitis, most of the pediatricians are prescribing salbutamol nebulization.
Yeah, yeah. In practically, we do nebulize with salbutamol.
Okay, so how often do you see any response to salbutamol in bronchiolitis?
Yeah, the response is good. As we practice here in periphery, we give nebulization with salbutamol, and the response is also good. And the duration of stay is also shortened after nebulization.
Okay, so the international guidelines say salbutamol nebulization has no role in bronchiolitis, but you can try salbutamol nebulization, and if there is any response, you have to follow this child up because he may land up being asthmatic or with a hyperresponsive airway disease. Exactly. So in our practice, do we do follow-ups in these kind of children?
Yeah, we do follow up. We do follow up. And later, whether the child has got, if he has got repeated similar problem, then we think of other causes like reactive airway disease. We can think of it.
Okay. Thank you, Dr. Kishore. Any other panelists? Any inputs, please?
Right. So basically, this bronchiolitis itself is a big topic, but making it short, this X-ray in bronchiolitis, even if it is suppose pneumonia, doing X-ray on day 1 or 2 doesn't help us much in deciding what we will give. X-ray even in pneumonia is indicated after 3 or 4 days of treatment, when either we are suspecting complications or we are suspecting pneumonias. So X-ray probably can be avoided on day 1 or day 2 of this kind of scenario. Regarding the role of nebulization, even the trial, the recent guideline has said that previous guideline do mention that the trial can be given, but the recent updated guideline doesn't recommend even the trial for the salbutamol nebulization in bronchiolitis. But I do agree with Dr. Khatri that in peripheral setting, sometimes we do use, even I use salbutamol nebulization just for the sake of the patient belief or the patient comfort. When the 3%.
Okay, so it is only for placebo effect?
Maybe.
Okay, so any other medications you would like to add or anything like in management? Because most of the time what I have seen even in Kathmandu also, in hospitals, a 8-month-old or 9-month-old child with wheeze who looks like a dipsnick, there is nasal flaring, and he lands up in the ICU setup where his hands and feet are tied up, and he gets irritated, and then they want to nebulize this child. He again gets more irritated, and he gets in distress, and they are changing antibiotics, adding up steroids after steroids, and the child doesn't improve.
I like to share with you my story a few years back, around 2 to 3 years back. The child has severe distress and tried to nebulize him, and the child just had respiratory arrest. So after that, I'm really very much cautious in using this nebulization in these distressed babies. It may just precipitate further bronchospasm and sometimes even can lead to respiratory failure or arrest.
Okay, thank you. Any other panelists?
Actually, regarding bronchiolitis, I think bronchiolitis, what the guideline says and what we are doing is completely different, because in most of the parts or most of the pediatricians, I think we are using nebulization, either salbutamol or adrenaline or 3% saline. So many times it may be the clinical decision. What the guideline says, and when we go deep into the guidelines and the studies mentioned there, that there might be some improvement or some clinical scoring may improve, but these are subjective assessment. The harm with using any kind of nebulization, be it salbutamol or adrenaline, is that the length of stay would increase in case of bronchiolitis, because when you give nebulization, you give it 6 hourly or 4 hourly, it does not improve. You increase the frequency of nebulization, and the child goes on to stay for 5 or 7 days, when he may not need so lengthy admission. So it is many a times it may be clinical decision. You just assess the improvement, but we regular use of any nebulization, whether it be salbutamol or adrenaline, I don't prefer that. But the guideline says about the 3% saline nebulization. If 3% saline nebulization is given for a short period, like if we expect less than 3 days of 3% saline nebulization, it's of no use. If it is being used for longer duration, more than 3 days, then the length of stay is has said to be decreased. But these are weak recommendations. These are not strong recommendations. So many a times management of bronchiolitis is clinical. But having said that, we should not go for medications like antibiotics, use of antibiotics, or use of steroid, and lengthen the hospital stay. And I think many a times we make clinical decisions regarding management of bronchiolitis.
Okay, thank you, Dr. Amrit. So, Dr. Rai or Dr. Satish, if you have anything to add, otherwise we'll move on to case 4.
Yes, what I practice over here, when I get a case of any respiratory distress below 2 years, I think about the bronchiolitis first thing. And what I do, I do acetylene nebulization to the patient, and if the patient improves, then I continue it. If the patient do not improve, then I go for the 3% normal saline, and that is also for just for the 2 or 3 days, not more than that. Because after giving for longer period 3% normal saline, that also start to irritate the patient and cough. Most of the time, what I see practically, that the patient start to cough for longer period, and that also prolong the stay. So first episode, sometime maybe a case of bronchial asthma, reactive airway disease. So if the patient improve with acetylene or adrenaline nebulization, then I continue. Otherwise, I stop after 1 or 2 days.
Okay, Dr. Rai?
Just simple measures like nasal clearance, we have to keep in mind. And also sometimes bronchiolitis may complicate with congestive heart failure. We have to be a bit vigilant perhaps. Otherwise,
Okay, thank you, sir. So we can conclude that bronchiolitis is a viral infection. The mechanism of obstruction is not similar to the asthma. So maybe salbutamol nebulization may not work. In peripheral setup, we may try with acetylene or adrenaline nebulization. If it improves, you may continue. Otherwise, you will stop.